Lewis's Medical Surgical Nursing, 11th edition, Chapter 43, Liver, Biliary Tract, and Pancreas Problems. Nursing management of patients with a wide range of liver, pancreatic, and gallbladder problems is the focus of this chapter. These organs are closely positioned together anatomically and highly associated in their digestive functions. Liver and pancreatic problems can lead to altered nutrient absorption and use, causing malnutrition and impaired elimination. Inflammation may be present, with the patient having pain, nausea, and vomiting. Nursing care focuses on helping the patient and caregiver manage symptoms and develop ways to cope with the diagnosis and sometimes prognosis. Health promotion focuses on reducing risk through immunizations and avoiding substance use. Disorders of the liver. Hepatitis. Hepatitis is inflammation of the liver. Hepatitis is most often caused by viruses. It also can be caused by substances, e.g. alcohol, medications, chemicals, autoimmune diseases, and metabolic problems. Viral hepatitis. There are several types of viral hepatitis. We designate each type by a letter, A, B, C, D, E. The different types have similar manifestations, but their modes of transmission and disease course vary. Some can lead to chronic liver disease. Other less common viruses also can cause liver disease. These include cytomegalovirus, CMV, Epstein-Barr virus, EBV, herpes virus, Coxsackie virus, and rubella virus. Hepatitis A virus. Hepatitis A is a self-limiting infection that can cause a mild flu-like illness and jaundice. In more severe cases, it can cause acute liver failure. Hepatitis A virus, HAV, is a ribonucleic acid RNA virus. It is transmitted primarily through the fecal-oral route. It often occurs in small outbreaks caused by fecal contamination of food or drinking water. Poor hygiene, improper handling of food, crowded situations, and poor sanitary conditions are contributing factors. Transmission occurs between family members, institutionalized persons, and children in daycare centers. Foodborne outbreaks are usually due to food contaminated by an infected food handler. People at increased risk for infection include drug users, both injection and non-injection drugs, men who have sex with men, and persons traveling to developing countries. The greatest risk for transmission occurs before clinical symptoms appear. The virus is found in feces 1 to 2 weeks before the onset of symptoms and at least 1 week after the onset of illness. This means it can be carried and transmitted by persons who have undetectable subclinical infections. It is present only briefly in the blood, usually less than 3 weeks. Fecal excretion can occur in infants for months. Anti-HAV immunoglobulin M, IgM, appears during the acute phase. Detection of hepatitis A IgM indicates acute hepatitis. Hepatitis A IgG without anti-HAV IgM indicates past infection. IgG antibody provides lifelong immunity. HAV vaccination and thorough hand washing are the best measures to prevent outbreaks. In the United States, the incidence of infection has declined since we started vaccinating at-risk persons and children, beginning 12 to 24 months. Hepatitis B virus. Hepatitis B virus, HBV, is a blood-borne pathogen that can cause either acute or chronic hepatitis. The incidence of HBV infection has decreased in areas where the use of the Hpv vaccine is widespread. Asians and Pacific Islanders have an incidence of HBV of up to 8%. Perinatal transmission is the most common mode of transmission in this population and often results in chronic HBV infection. HBV is a DNA virus. It can be transmitted in several ways. 1. Perinatally from mothers infected with HBV to their infants. 2. Percutaneously, e.g. IV drug use, accidental needle stick punctures. Or 3. By small cuts on mucosal surfaces and exposure to infectious blood, blood products, or other body fluids, e.g. semen, vaginal secretion, saliva. Sexual transmission is a common mode of HBV transmission. MSM, especially those practicing unprotected anal intercourse, are at increased risk for HPV infection. Most believe that casual encounters, like hugging, kissing, and sharing utensils, do not transmit the disease. Other at-risk persons include those who live with chronically HPV-infected persons, patients on hemodialysis, healthcare personnel, public safety workers, IV drug users, recipients of blood products, and Native Alaskans, Pacific Islanders, and Native Americans. HPV has been detected in almost every body fluid. Infected semen, cervicovaginal secretions, and saliva contain much lower concentrations of HPV than blood, but the virus can be transmitted via these secretions. If GI bleeding occurs, feces can be contaminated with the virus from the blood. There is no evidence of fecal-oral transmission. Organ and tissue transplantation is another potential source of infection. However, in some patients with acute hepatitis B, there is no readily identifiable risk factor. HPV is a complex structure with three distinct antigens: surface antigen, HBsAg, core antigen, HBcAg, and E antigen, HBeAg. Each antigen, along with its corresponding antibody, may appear or disappear in serum depending on the phase of infection and immune response. In most people who acquire HPV infection as an adult, the infection completely resolves without any long-term complications. In those who develop chronic HPV infections, the liver may range from a normal-appearing liver to severe liver inflammation and scarring, fibrosis. Around 25% of those who become chronically HPV infected in childhood die from complications of chronic liver disease, including liver cancer. Screening for HPV usually includes identifying those at high risk for infection and testing the blood for the presence of hepatitis B surface antigen, HBsAg, hepatitis B antibody, anti-HBs, and hepatitis B core antibody, anti-HBC. The presence of anti-HBs in the blood indicates immunity from the Hpv vaccine or from past HBV infection. HBsAg in the serum for 6 months or longer after infection indicates chronic HBV infection. Hepatitis C virus. Hepatitis C virus, HCV, causes a type of hepatitis that can result in both acute illness and chronic infection. Acute hepatitis C, which can be mild in presentation, can be hard to detect unless a diagnosis is made with laboratory testing. The most common causes of acute hepatitis C outbreaks are among injection drug users and MSM with HIV infection. HCV is an RNA virus that is bloodborne and primarily transmitted percutaneously. The most common mode of HCV transmission is the sharing of contaminated needles and equipment among injection drug users. High-risk sexual behavior, e.g. unprotected sex, multiple partners, especially among MSM, is associated with increased risk for transmission. After a needle stick exposure or sharps exposure to HCV-positive blood, the transmission rate is 0.1%. The risk for perinatal HCV transmission is 4 to 7% per pregnancy. Persons who were given blood or blood products before 1992, when blood product testing for HCV began, are at higher risk for chronic HCV infection and should be routinely tested. Some patients with HCV infection cannot identify a source of infection. Most patients usually develop chronic infection. However, because signs and symptoms of HCV infection are generally mild, most people are unaware of their infection. HCV is the most common cause of chronic liver disease and liver failure. About 20 to 30% develop cirrhosis and eventually liver failure and or liver cancer. Along with chronic HBV, HCV accounts for most cases of liver cancer. HCV hepatitis is the most common reason for liver transplantation in the United States. Because of the 15 to 20-year delay between infection and the manifestations of liver damage, long-term effects of HCV infection pose important healthcare challenges. Persons at risk for HCV infection are also at risk for HPV and HIV infections. About 30 to 40% of HIV-infected patients also have HCV. This high rate of co-infection is primarily related to IV drug use. Co-infection with HIV and HCV places the patient at greater risk for progression to cirrhosis. People in the United States born between 1945 and 1965 and those at increased risk should be screened for HCV infection. This includes people who engage in high-risk sexual practices, injection drug users, and those who may have had blood or blood products prior to 1992, and or those who have abnormal liver function tests. A positive antibody test for HCV, anti-HCV, is usually enough for a diagnosis. However, a positive viral load is needed to confirm active infection because anti-HCV can also indicate a past infection. Hepatitis D virus. Hepatitis D virus, HDV, also called Delta virus, is uncommon in the United States. HDV is a defective single-stranded RNA virus that cannot survive on its own. It requires Hpv surface Ag to serve as its outer shell. So only those who are infected with HBV can be infected with HDV. It can be acquired at the same time as HBV, or a person with HBV can be infected with HDV later. HDV is transmitted like HBV. It can cause a range of illness from an asymptomatic chronic carrier state to acute liver failure. There is no vaccine for HDV. However, vaccination against HBV reduces the risk for HDV co-infection. Hepatitis E virus. Like hepatitis A, the hepatitis E virus, HEV, is an RNA virus transmitted by the fecal-oral route. The usual mode of transmission is drinking contaminated water. HEV infection occurs primarily in developing countries, with epidemics reported in India, Asia, Mexico, and Africa. Only a few cases of HEV have been reported in the United States. These have been primarily in persons who recently traveled to an HEV endemic area. It is generally acute and self-resolving, but chronicity in immunosuppressed persons, such as liver transplant recipients, has been reported. Pregnant women may be affected severely, with reported mortality rates of up to 10%. An IgM antibody assay is available to test for acute hepatitis E. Pathophysiology. Liver. In viral hepatitis, hepatocytes become targets of the virus in one of two ways: through direct action of the virus, as in HCV infection, or through a cell-mediated immune response to the virus, as in HBV and HCV infection. During acute viral hepatitis, large numbers of infected hepatocytes are destroyed. The destruction of hepatocytes leads to a wide range of liver-related dysfunction. Bile production, coagulation, blood glucose, and protein metabolism can be affected. Detoxification and processing of drugs, hormones, and metabolites, e.g. ammonia from protein catabolism, may be disrupted. After resolution of an acute infection, liver cells can regenerate. If no complications occur, the liver can resume its normal appearance and function. In certain cases, the acute hepatitis can become so severe and irreversible that people develop liver failure or die. Chronic viral hepatitis can be insidious and silent, causing persistent and continual destruction of infected hepatocytes. Over time, scar tissue can develop, which leads to fibrosis and compromised liver function. Fibrosis can lead to cirrhosis and liver failure. Cirrhosis is a generally irreversible condition that can increase one's risk for liver dysfunction, portal hypertension, and primary liver cancer. Cirrhosis is discussed later in this chapter. Systemic effects. In the early phases of hepatitis infection, antigen-antibody complexes between the virus and its corresponding antibody may form circulating immune complexes. The circulating immune complexes activate the complement system, see Chapter 11. The manifestations of this activation are rash, angioedema, arthritis, fever, and malaise. Cryoglobulinemia, abnormal proteins found in the blood, glomerulonephritis, vasculitis, and involvement of other organs can occur from immune complex activation. Clinical manifestations and complications. The manifestations of the different viral hepatitis infections can be classified into acute hepatitis and chronic hepatitis. Acute hepatitis. Many patients with acute hepatitis have no symptoms and may not even know they have been infected. However, others may have intermittent or ongoing anorexia, lethargy, nausea, vomiting, skin rashes, diarrhea or constipation, malaise, fatigue, myalgias, arthralgias, other flu-like symptoms, and right upper quadrant tenderness caused by liver inflammation. Although the acute phase of viral hepatitis varies depending on the type of hepatitis, it usually lasts from 1 to 6 months. During this time, the patient may have a decreased sense of smell and find food repugnant. Smokers may have distaste for cigarettes. Physical examination often reveals hepatomegaly, lymphadenopathy, abdominal tenderness, and sometimes splenomegaly. The acute phase is the period of maximal infectivity. A patient in the acute phase of hepatitis may be icteric, jaundiced, or anicteric. Jaundice, a yellowish discoloration of body tissues, results from a change in normal bilirubin metabolism or disruption of the flow of bile into the hepatic or biliary duct systems. The types of jaundice are described in Table 43.3. The urine may appear darker due to excess bilirubin being excreted by the kidneys. If conjugated bilirubin cannot pass into the intestines from the liver because of the obstruction or inflammation of the bile ducts, the stools will be clay-colored. Pruritus, intense generalized itching, sometimes accompanies jaundice. It occurs from the accumulation of bile salts beneath the skin. Itching can be intolerable to the patient. As jaundice fades, the convalescence phase begins. The convalescent phase can last for weeks to months, with an average of 2 to 4 months. During this period, patients typically have malaise and easy fatigability. Hepatomegaly remains for several weeks. Splenomegaly, if present, subsides during this period. Most patients with acute viral hepatitis recover completely. Almost all cases of acute hepatitis A resolve. However, some patients may have a relapse in the first 2 to 3 months after the infection. The disappearance of jaundice does not mean the patient has totally recovered. Some HBV infections and most HCV infections result in chronic hepatitis. The overall mortality rate for acute hepatitis is less than 1%. The mortality rate is higher in older adults and those with underlying debilitating illnesses, including chronic liver disease. Complications that can result from acute hepatitis are acute liver failure, chronic hepatitis, cirrhosis of the liver, portal hypertension, and liver cancer. Acute liver failure. Sometimes acute liver failure, fulminant hepatic failure, may occur, which is a serious condition with a poor prognosis. Manifestations include encephalopathy, GI bleeding, disseminated intravascular coagulation, DIC, fever with leukocytosis, renal manifestations, oliguria, azotemia, ascites, edema, hypotension, respiratory failure, hypoglycemia, bacterial infections, thrombocytopenia, and coagulopathies. Liver transplantation is usually the cure for these patients. Acute liver failure is discussed in this chapter on page 989. Chronic hepatitis. Manifestations of chronic hepatitis are shown in Table 43.2. Chronic HBV is more likely to develop in infants born to infected mothers and in those who acquire the infection before age 5 than in those who acquire the virus after age 5. Problems with the patient's cellular immune response may be important in the development of the chronic HBsAg carrier state and the progression of acute HBV to chronic HBV. More than 50% of immunocompromised adults who are acutely infected with HBV progress to chronic infection. HCV infection is more likely than HBV to become chronic. As previously mentioned, many patients with chronic HCV infection develop chronic liver disease, cirrhosis, portal hypertension, and liver cancer. Risk factors for progression to cirrhosis include male gender, alcohol use, concomitant fatty liver disease, and excess iron deposition in the liver. In some patients, co-infection with HIV may cause complications or require treatment modification. Manifestations of chronic hepatitis include anemia and coagulation problems, easy bruising, bleeding. Since the liver produces clotting factors, clotting and bleeding times can be impaired or prolonged. Skin manifestations may include spider angiomas, palmar erythema, and gynecomastia. Some patients have spleen, liver, or cervical lymph node enlargement. In patients with severe liver damage, hepatic encephalopathy is a potentially life-threatening spectrum of neurologic, psychiatric, and motor disturbances. Hepatic encephalopathy results from the liver's inability to remove toxins, especially ammonia, from the blood. Hepatic encephalopathy is discussed later in this chapter. Ascites, a common manifestation of hepatitis, especially chronic hepatitis, is the accumulation of excess fluid in the peritoneal cavity. Fluid accumulates due to reduced protein levels in the blood, which reduces the plasma oncotic pressure. Ascites is discussed later in this chapter on page 982. Diagnostic studies. The only definitive way to distinguish among the types of viral hepatitis is by testing the patient's blood for the specific antigen or antibody. In some types of viral hepatitis, the blood can be tested for the viral load, viral level. Tests for the different types of viral hepatitis are outlined in Table 43.4. Many liver function tests show significant abnormalities, as shown in Table 43.5. Several tests are available to determine the presence of HCV. The screening test for HCV infection is HCV antibody testing. Antibodies can be detected within 4 weeks of infection. If the antibody test is positive, HCV RNA testing is done to assess for chronic infection. A positive result confirms chronic infection. A few patients may have a false positive HCV antibody result with a negative HCV RNA test. If recent HCV infection is suspected, HCV RNA testing is usually done because it may take several weeks or longer for HCV antibodies to develop. HCV RNA testing may be used for immunocompromised patients, e.g., patient with HIV. Because of altered or delayed antibody response to HCV, these patients may not have detectable antibody levels even if they are infected with HCV. Viral genotype testing is done in patients undergoing drug therapy for HBV or HCV infection. HBV has at least 8 different genotypes, A to H. In some centers, HBV genotyping is done before starting treatment. HBV genotype may be useful in predicting disease course and treatment outcomes. HBV core AB, IgG, indicates that the patient has a history of HBV infection. HBV may reactivate in these patients if they become immunosuppressed. HCV has 6 genotypes and more than 50 subtypes. In the United States, 75% of HCV infections are caused by HCV genotype 1. For patients who test positive for HCV, genotyping is done before drug therapy is started. The genotype determines the choice and duration of therapy. It is one of the strongest predictors of a patient's response to drug therapy. A liver biopsy is done in acute hepatitis only if diagnosis is in doubt. In chronic hepatitis, a liver biopsy allows for histologic examination of liver cells and determination of the degree of inflammation, fibrosis, or cirrhosis that may be present. A patient who has a bleeding disorder may not be a candidate for a percutaneous liver biopsy because of the risk for bleeding. In these patients, a transjugular biopsy may be an alternative. This type of biopsy consists of obtaining liver tissue through a rigid cannula introduced into a hepatic vein, typically using jugular venous access. Techniques for non-invasive assessment of liver fibrosis are increasingly replacing the need for liver biopsy. One option is the use of ultrasound elastography, e.g. FibroScan, which uses an ultrasound transducer to determine the degree of liver fibrosis. FibroSure FibroTest is an example of one of several biomarkers that uses the results of serum tests to assess the extent of hepatic fibrosis. Interprofessional care. There is no specific treatment for acute viral hepatitis. Most patients are managed at home. Emphasis is on providing adequate nutrition and measures to rest the body to help the liver to regenerate and repair. Rest reduces the metabolic demands on the liver and promotes liver cell regeneration. The degree of rest depends on the severity of symptoms, but usually alternating periods of activity and rest are adequate. Counseling should include the importance of avoiding alcohol and notifying contacts for testing and prophylaxis, if indicated. In patients with chronic viral hepatitis, care may involve hepatologists, infectious disease specialists, pharmacists, dietitians, and mental health or substance use specialists. The role and extent of involvement of team members is based on the patient's specific needs. Drug therapy. Acute hepatitis. There are no drug therapies for treating acute HAV infection. Treatment of acute HBV may be indicated only in patients with severe hepatitis and liver failure. In acute hepatitis C, some patients may choose to be monitored for spontaneous clearance of the infection. For patients who choose treatment, one of the direct-acting antivirals, DAAs, may be used. DAAs are discussed later in the section on chronic hepatitis. Supportive drug therapy may include antihistamines for generalized itching and antiemetics for nausea. These drugs include promethazine, Phenergan, and ondansetron, Zofran. Chronic hepatitis B. Drug therapy for chronic HBV focuses on decreasing the hepatitis B viral load and liver enzymes, and in turn, slowing the rate of disease progression. Long-term goals are preventing the development of cirrhosis, portal hypertension, liver failure, and liver cancer. Current drug therapies for chronic HBV do not eradicate the virus but suppress viral replication and prevent complications of infection. First-line therapies now include primarily nucleoside and nucleotide analogs, and sometimes interferon therapy. Nucleoside and nucleotide analogs. Nucleoside and nucleotide analogs inhibit viral DNA replication. HBV reproduces by making copies of its viral DNA nucleosides and nucleotides. The nucleoside and nucleotide analog drugs mimic normal building blocks for DNA, but are actually faulty viral DNA building blocks. Once they become incorporated into the viral DNA, they halt DNA synthesis. Nucleoside and nucleotide analogs do not prevent all viral reproduction, but they can substantially lower the amount of virus in the body. These medications include lamivudine, Epivir, adefovir, Hepcera, entecavir, Baraclude, telbivudine, Tazica, and tenofovir, Viread. These oral medications are used to treat chronic HBV when there is evidence of significant active viral replication and liver inflammation. These drugs also reduce viral load, decrease liver damage, and decrease serum liver enzyme levels. Most patients with HBV need long-term treatment. When these drugs are stopped, many patients, except those who have seroconverted, HBV DNA and liver enzyme levels return to pre-treatment levels. Severe exacerbations of hepatitis B can develop after ending treatment. If these drugs are stopped for any reason, closely monitor liver function for several months. Interferon. Interferon is a naturally occurring immune protein made by the body during an infection to recognize and respond to pathogens. It has antiviral, anti-proliferative, and immune modulating effects. Interferon is discussed in Chapter 13. Pagulated interferon, PEG-intron, Pegasus, is given by subcutaneous injection. The many side effects with interferon therapy, including flu-like symptoms, e.g. fever, malaise, fatigue, make adhering to therapy hard for some patients. Currently, the availability of better tolerated and more effective oral treatments limits interferon use. However, it is still among the first-line options recommended by hepatology societies. Patients receiving interferon should have blood counts and liver function tests every 4 to 6 weeks. Depression is a side effect of interferon. Patients must be screened for depression and other mood disorders before starting interferon therapy and monitored frequently while in therapy. Chronic hepatitis C. Treatment of chronic hep C is patient-specific and based on the genotype of the HCV, severity of liver disease, and presence of other health problems, e.g. HIV. Goal of drug therapy is eradicating the virus and preventing HCV-related complications. Treatment for HCV primarily includes the use of DAAs, which block proteins needed for HCV replication. With DAAs, patients typically complete a 12-week regimen with oral drugs. Almost all, greater than 95%, of those who complete treatment with the DAAs are now able to cure their chronic HCV infection. Many patients with HIV also have HCV. Patients who have stable HIV and intact immune systems, CD4 plus counts greater than 200 per microliter, receive HCV treatment with the goal of eradicating HCV and reducing the risk for progression to cirrhosis. HCV treatment may reduce CD4 plus counts and increase the patient's risk for anemia and leukopenia. Patients with advanced fibrosis or cirrhosis can undergo drug therapy if liver decompensation, e.g. ascites, variceal rupture, jaundice, wasting, and encephalopathy is not present. Nutritional therapy. No special diet is needed in the treatment of viral hepatitis. Emphasis is placed on a well-balanced diet that the patient can tolerate. During acute viral hepatitis, adequate calories are important because the patient usually loses weight. If fat content is poorly tolerated because of decreased bile production, it should be reduced. Vitamin supplements, particularly B complex and vitamin K, are often given. If anorexia, nausea, and vomiting are severe, IV solutions of glucose or supplemental enteral nutrition (EN) therapy may be used. Fluid and electrolyte balance must be maintained. Nursing management, viral hepatitis. Nursing assessment. Subjective and objective data that should be obtained from a person with hepatitis A are outlined in Table 43.8. Nursing diagnoses. Nursing diagnoses for the patient with viral hepatitis may include impaired nutritional intake, activity intolerance, risk for bleeding. Planning. The overall goals are that the patient with viral hepatitis will 1. Have relief of discomfort, 2. Be able to resume normal activities, and 3. Return to normal liver function without complications. Nursing implementation. Health promotion. Viral hepatitis is a public health problem. Your role is important in the prevention and control of this disease. It is helpful to understand the epidemiology of the different types of viral hepatitis when considering appropriate control measures. Preventative and control measures for hepatitis A, B, and C are outlined in Table 43.9. A suggested guideline for general practice to prevent you from contracting viral hepatitis from diagnosed and undiagnosed patients and carriers is for you to wear disposable gloves, goggles, and gowns sometimes when fecal or blood contamination is likely in handling 1. Soiled bedpans, urinals, and catheters, and 2. When the patient's bed linens are soiled by body excreta or secretions. Hepatitis A. Viral hepatitis outbreaks are usually due to HAV. Preventative measures include personal and environmental hygiene and health education to promote good sanitation. Hand washing is the most important precaution. Teach about careful hand washing after bowel movements and before eating. Vaccination is the best protection against HAV. All children at 1 year of age should receive the vaccine. Adults at risk should also receive the vaccine. These include people who travel to areas with increased rates of hepatitis A, MSM, injecting and non-injecting drug users, persons with clotting factor disorders, e.g. hemophilia, and persons with chronic liver disease. Hpv vaccine is inactivated Hpv protein. There are two forms of Hpv vaccine in the United States, Havrix and Vacta. Primary immunization consists of one dose given IM in the deltoid muscle. A booster is recommended 6 to 12 months after the first dose to ensure adequate antibody titers and long-term protection. Primary immunization provides immunity within 30 days after one dose in more than 95% of those vaccinated. Twinrix, a combined HAV and HBV vaccine, is available for people over 18 years of age. Immunization consists of 3 doses, given on a 0, 1, and 6-month schedule, the same schedule as that used for the single HBV vaccine. Twinrix may be given to high-risk persons, including patients with chronic liver disease, users of illicit IV drugs, patients on hemodialysis, MSM, and people with clotting factor disorders who receive therapeutic blood products. The side effects of the vaccine are mild and usually limited to soreness and redness at the injection site. Isolation is not needed for HAV infection. For a patient with HAV infection, use infection control precautions. Place the patient who is incontinent of stool or has poor personal hygiene in a private room. Both hepatitis A vaccine and IG are used to prevent HAV infection after exposure to an infected person. Post-exposure prophylaxis. The vaccine is used for pre-exposure prophylaxis. IG can be given either before or after exposure. IG gives temporary, 1 to 2 months, passive immunity and is effective for preventing hepatitis A if given within 2 weeks after exposure. IG is recommended for persons who do not have anti-HAV antibodies and were exposed by close household, daycare center, contact with persons who have HAV or foodborne exposure. Because patients with HAV are most infectious just before the onset of symptoms, the pre-icteric phase, those exposed through household contact or foodborne outbreaks should receive IG. Although IG may not prevent infection in all persons, it may lessen the illness to a subclinical infection. When hepatitis A occurs in a food handler, IG should be given to all other food handlers at the establishment. Patrons may need to receive IG. Persons exposed to HAV who have received a dose of HAV vaccine more than 1 month previously, or who have a history of laboratory-confirmed HAV infection, do not need IG. Hepatitis B. The best way to reduce HBV infection is to identify those at risk, screen them for HBV, and vaccinate those who are not infected. Teach those at high risk for contracting HBV to reduce risk by following good hygienic practices, including hand washing and using gloves when expecting contact with blood. Patients should not share razors, toothbrushes, and other personal items. Teach patients to use a condom for sexual intercourse. In addition, the partner should be vaccinated. The HBV vaccine is the best means of prevention. The HBV vaccines, Recombavax HB, Engerix B, contain HBsAg, which promotes the synthesis of specific antibodies directed against HBV. The vaccine is given in a series of 3 IM injections in the deltoid muscle. The second dose is given within 1 month of the first dose, and the third dose within 6 months of the first. The vaccine is more than 95% effective. Minor reactions include transient fever and soreness at the injection site. The vaccine can be given in pregnancy. The first dose of hepatitis B vaccine should be given at birth, with the vaccine series completed by age 6 to 18 months. Older children and adolescents who did not receive the hepatitis B vaccine should be vaccinated. It is important to vaccinate adults who are in the at-risk groups and are not immune. Household members of a patient with HBV should be tested and vaccinated if they are HBsAg and antibody negative. Hepatitis vaccination is recommended for patients with chronic kidney disease before they start dialysis. Dialysis patients should routinely have their antibody titer levels checked to determine the need for revaccination. For post-exposure prophylaxis, the Hpv vaccine series and hepatitis B immune globulin (HBIG) are given. HBIG has antibodies to HPV and confers temporary passive immunity. HBIG is prepared from plasma of donors with a higher titer of anti-HBs. HBIG is recommended for post-exposure prophylaxis in cases of needle stick, mucous membrane contact, or sexual exposure, and for infants born to mothers who are positive for HBsAg. Ideally, HBIG should be given within 24 hours of exposure. Giving antiviral therapy, e.g. tenofovir, to pregnant women in the third trimester with viral levels over 200,000 IU per milliliter can prevent the small risk for neonatal infection that may occur even with postnatal immunization and vaccination. The CDC recommends following standard precautions for the patient with HPV. This includes using disposable needles and syringes and disposing of them in puncture-resistant units without recapping, bending, or breaking. Hepatitis C. No vaccine is currently available for hepatitis C. Therefore, it is important to identify those at high risk for contracting HCV and teach them how to reduce their risks. Primary measures to prevent HCV transmission include 1. Screening of blood, organ, and tissue donors, 2. Using infection control precautions, and 3. Modifying high-risk behavior. In the United States, there are many people who have undiagnosed hepatitis C. Therefore, the CDC recommends universal screening for all persons born between 1945 and 1965. CD does not recommend IG or antiviral agents, e.g. interferon, for post-exposure prophylaxis for HCV infection, e.g. needle stick exposure from an infected patient. After an acute exposure, e.g. needle stick, the person should have anti-HCV testing done. For the person exposed to HCV, baseline anti-HCV and ALT levels should be measured, with follow-up testing at 4 to 6 months. Testing for HCV RNA may be done after 4 to 10 weeks. Acute care. In patients with hepatitis, assess for the presence and degree of jaundice. In light-skinned persons, jaundice is usually seen first in the sclera of the eyes, and later in the skin. In dark-skinned persons, jaundice is seen in the hard palate of the mouth and inner canthus of the eyes. The urine may have a dark brown or brownish-red color from bilirubin excretion from the kidneys. Comfort measures to relieve itching, headache, and arthralgias are helpful. Arthralgia is joint stiffness. Ensuring that the patient receives adequate nutrition is not always easy. The anorexia and distaste for food may cause nutritional problems. Assess the patient's tolerance of specific foods and eating pattern. Small, frequent meals may be preferable to 3 large ones and may help prevent nausea. Often, a patient with hepatitis finds that anorexia is not as severe in the morning, so it is easier to eat a good breakfast than a large dinner. Include measures to stimulate the appetite, such as mouth care, antiemetics, and attractively served meals in pleasant surroundings in the care plan. Drinking carbonated beverages and avoiding very hot or cold foods may help ease anorexia. Adequate fluid intake, 2,500 to 3,000 ml per day, is important. Rest is a critical factor in promoting hepatocyte regeneration. Assess the patient's response to the rest and activity plan. Modify it as needed based on liver function tests and symptoms. Psychological and emotional rest is as essential as physical rest. Limited activity may produce anxiety and restlessness in some patients. Diversion activities such as reading and hobbies may help the patient cope with the plan of care and ensure adequate rest. Ambulatory care. Most patients with viral hepatitis are cared for at home. Assess the patient's knowledge of nutrition and provide any needed dietary teaching. Caution the patient about overexertion and the need to follow the HCP's advice about when to return to work. For patients who have fatigue, tell them to plan activities after periods of rest when energy levels are highest. Teach the patient and caregiver how to prevent transmission to other family members and symptoms to report to the HCP. Assess the patient for any signs of complications. These include bleeding tendencies with increasing prothrombin time values, manifestations of encephalopathy. Sudden increase in weight and abdominal girth may indicate fluid retention and/or ascites. Bloody or tarry stools, vomiting of blood, or elevated liver enzymes. Teach the patient to have regular follow-up for at least 1 year after the diagnosis of hepatitis. Because relapse occurs with hepatitis B and C, teach the patient the symptoms of recurrence and the need for follow-up evaluations. All patients with chronic HBV or HCV should avoid alcohol as it can accelerate disease progression. Note that patients who are positive for HBsAg, chronic carrier status, or HCV antibody cannot be blood donors. Evaluation. Expected outcomes are that the patient with hepatitis will maintain food and fluid intake adequate to meet nutritional needs, avoid alcohol and other hepatotoxic agents, show gradual increase in activity tolerance, perform daily activities with scheduled rest periods. Drug and chemical-induced liver diseases. Alcohol use is the most frequent cause of both acute and chronic liver disease. It can cause injury and necrosis of liver tissue. Alcohol use can cause a spectrum of manifestations, ranging from mild elevation in liver enzymes to acute alcoholic hepatitis. It may also cause advanced fibrosis and cirrhosis, which usually occurs after decades of excess alcohol use. Patients may have serious liver disease caused by another chronic disease, e.g. chronic HCV infection, in combination with alcoholic liver disease, which can compound the problem. Acute alcoholic hepatitis is a syndrome of hepatomegaly, jaundice, elevated liver enzymes, AST, ALT, alkaline phosphate, and low-grade fever with possible ascites and prolonged PT time. These manifestations may improve if alcohol intake ceases. Even at the end stage of cirrhosis, abstinence can result in significant reversal in some patients. If liver function does not recover after abstaining from alcohol for 6 months or longer, liver transplantation may be considered. Chemical hepatotoxicity is liver injury caused by exposure to certain compounds, e.g. carbon tetrachloride, gold compounds. Some agents can cause hepatotoxicity, while others may induce cholestasis, necrosis, or liver cancer. Fortunately, because of the decreased use of these agents, the incidence of chemically induced liver toxicity has decreased since the 1980s. Drug-induced liver injury, DILI, can present similarly to other forms of liver disease. The main cause of DILI is antimicrobial agents, especially amoxicillin clavulanate. Many drugs, prescription, OTC, diet, and herbal supplements can cause an increase in liver enzymes and, in severe cases, jaundice and acute liver failure. The pattern of injury depends on the drug causing the reaction. The most common cause of acute liver failure is acetaminophen. In patients with chemical hepatotoxicity, or DILI, all drugs identified as the cause of liver injury should be stopped. Autoimmune, genetic, and metabolic liver diseases. Autoimmune hepatitis. Autoimmune hepatitis is a chronic inflammatory disorder of the liver in which the patient's own immune system attacks the liver. The cause of this condition is unknown. Autoimmune hepatitis is characterized by the presence of autoantibodies and high levels of serum immunoglobulins. It often occurs with other autoimmune diseases. Most patients with autoimmune hepatitis are women. Laboratory tests useful in the diagnosis include anti-nuclear antibody, ANA, anti-smooth muscle antibody, ASMA, and anti-mitochondrial antibody, AMA testing. A liver biopsy is often done to confirm the diagnosis and guide the treatment decision. Although autoimmune hepatitis can cause acute liver failure, the spectrum of disease is variable. Most patients develop chronic hepatitis. Untreated autoimmune hepatitis can progress to cirrhosis. Prednisone with or without azathioprine, Imaran, is recommended treatment for active autoimmune hepatitis. Cyclosporin, Gengraph, tacrolimus, Prograph, FK506, budesonide, Entecort, methotrexate, mercaptopurine, and mycophenolate mofetil, Cellcept, are options in those who do not respond to prednisone and azathioprine. Mycophenolate is most often used for patients intolerant to azathioprine. Wilson's disease. Wilson's disease is an autosomal recessive disorder involving cellular copper transport. A defect in biliary excretion leads to accumulation of copper in the liver, causing progressive liver injury and cirrhosis. About 30 people per million have Wilson's disease. It usually appears between ages 5 and 35. Once cirrhosis occurs, copper leaks into the plasma, leading to multiple complications, including neurologic, hematologic, and renal disease. The hallmark of Wilson's disease is corneal Kayser-Fleischer rings. These are brownish-red rings seen in the cornea near the limbus on eye examination. Low serum ceruloplasmin levels and markedly elevated copper concentrations from liver biopsy samples are present. Diagnosis is based on clinical findings, including the corneal rings and neurologic symptoms. First-degree relatives of patients with Wilson's disease should be screened for the disease. The recommended first treatment of symptomatic patients or those with active disease is chelating agents such as D-penicillamine, supramine, or trientine, cyprine. They promote the excretion of urinary copper. Zinc acetate, Galzin, another therapy, interferes with copper absorption. Once we have reduced the amount of copper in the body, treatment focuses on preventing copper from building up again. Liver transplantation may be an option with severe liver damage. Hemochromatosis. Hemochromatosis is a condition in which excess iron accumulates in the body. It is primarily caused by a genetic deficit, hereditary hemochromatosis. It also can be caused by liver disease and chronic blood transfusions used to treat thalassemia and sickle cell disease. Hemochromatosis is discussed in Chapter 30. Primary biliary cholangitis. PBC, formerly known as primary biliary cirrhosis, is a chronic disease of the small bile ducts of the liver. In PBC, there is a T-cell mediated attack of the small bile duct cells, resulting in loss of bile ducts and cholestasis, blockage of bile flow. Over time, this leads to liver fibrosis and cirrhosis. Most patients diagnosed with PBC are middle-aged women. The disease is associated with other autoimmune disorders such as rheumatoid arthritis, Sjogren's syndrome, and scleroderma. High serum alkaline phosphate levels, AMAs, ANAs, and serum lipid levels occur in patients with PBC. The goals of treatment are suppressing ongoing liver damage, preventing complications, and symptom management. Drugs for PBC include ursodeoxycholic acid, ursodeol, Actigol, a bile acid, and obeticholic acid, Ocaliva. It decreases bile in the liver. Management focuses on preventing or minimizing malabsorption, skin disorders such as itching and xanthomous, cholesterol deposits in the skin, hyperlipidemia, vitamin deficiencies, anemia, and fatigue. Cholestyramine is used to treat itching. Patients are monitored for progression to cirrhosis. Liver transplantation is an option for end-stage liver disease in patients with PBC. Primary sclerosing cholangitis. PSC is a disease of unknown cause characterized by chronic inflammation, fibrosis, and strictures narrowing of the medium and large bile ducts, both inside and outside the liver. Most patients with PSCs also have ulcerative colitis or, less often, Crohn's disease. Complications of PSC can include cholangitis, cholestasis with jaundice, bile duct cancer, and cirrhosis. Drug therapy has no proven benefit, although many HCPs use ursodiol. Treatment is directed at reducing the incidence of biliary complications and screening for bile duct and colorectal cancer, which is related to the high incidence of ulcerative colitis. Patients with advanced liver disease may need liver transplantation. Non-alcoholic fatty liver disease and non-alcoholic steatohepatitis. NAFLD refers to a wide spectrum of liver diseases ranging from a fatty liver, steatosis, to non-alcoholic steatohepatitis, NASH, to cirrhosis. The term non-alcoholic is used because NAFLD and NASH occur in people who do not consume excess amounts of alcohol. The fundamental characteristic of NAFLD is the accumulation of fatty infiltration in the hepatocytes. In NASH, the fat accumulation is associated with varying degrees of inflammation and fibrosis of the liver. If NASH is untreated, it can become a serious liver disease leading to cirrhosis, liver cancer, and liver failure.